welcome back to episode 2 of Hidradenitis suppurativa. Oh wait, no, that's wrong. Skin Hidradenitis, where we talk about Hidradenitis suppurativa, which I will abbreviate to HS for the rest of the podcast. So today we're just going to be looking at management options and basically what sort of things you can do at home or what you can talk to with your GP or what they might suggest when managing Hidradenitis suppurativa. So when it comes to treating HS, there are some overall goals we are looking to achieve. However, none of these goals currently involve treatment, but rather the management of symptoms such as pain, journeys of the lesions, and decreasing the frequency of HS recurrence to prevent HS from progressing to worse stages. For example, like we talked in our last episode, preventing progressions from early stages 1 to 2, stage 2 to 3, and so on. Now, the studies that are currently available are limited when it comes to comparing the efficacy of treatment regimens. Most of these treatment algorithms, although research, are based mostly on expert opinion and consensus. So now I'm going to list all of the sort of known treatments and management options available that I've personally found, and these are in no particular order. And they are lifestyle modifications, pain management techniques, antibiotics, local therapy and wound care, administration of biologics, surgical modalities, laser therapy, which is something I have the most personal interest in, and other systemic therapies. The really important thing to consider is that regardless of what stage of HS you are in, the first thing in treatment should most likely address any comorbidities that contribute heavily to development or worsening of HS and its progression. We mentioned a lot of these in the first episode, but generally these are those who are above the ideal weight for what is generally considered average for an individual. So obesity and starting the journey to eventually quit smoking, as smoking can cause the disease to progress. And both of these goals are a lot easier to say than to actually do, so it's really a difficult topic. And before we dive deeper into our treatment management, one important point to make is that the psychological aspect of this disease is often overlooked in many diagnoses and treatment plans. The quality of life of individuals with HS is heavily diminished because the condition is associated with higher levels of pain, intense drainage, heavy odor, and increased sensitivity of afflicted areas. People with HS have a higher chance of being socially isolated and have increased employment difficulties because of the unpredictable occurrence of flare-ups. The main method to help with the psychological aspect of this disease is constant assurance that the condition is not contagious to other people and is not the result of poor hygiene and sanitation. Okay, now let's get into the physical modalities, techniques, management options, and treatments we can use to help individuals with HS. First, let's get into the simple and deceptively simple lifestyle modifications. As we know, smoking and obesity are some of the leading comorbidities that increase the severity of HS. The most common recommendation that patients get is to stop smoking and reduce their body weight, which for many people, again, is easier said than done. Another method is to wear loose-fitting clothes to avoid friction and mechanical stress in the areas of flexions, I guess you can call it. Avoiding skin trauma is very crucial to stopping the progression of HS. So articles of clothing that are tight and synthetic, have harsh products, and cleaning tools like washcloths, brushes, and loofahs should genuinely be avoided, as these are abrasive and, most importantly, if they are not properly maintained, they are a breeding ground for bacteria, and that can cause an infection in those of HS because of all those open wounds and drainage and leakage from the areas. Avoiding adhesive dressings in areas also can be effective. So these are like one example of adhesive dressings are the brand Band-Aid. So swapping these out for soft dressings or something with clear petroleum jelly, so maybe like Vaseline, or a non-occlusive dressing can be used to prevent drainage without further irritating the area. Pain management is important in chronic conditions such as HS, as pain is a huge contributor to the quality of life of HS sufferers. The main goal is to reduce the amount of inflammation in the area through modalities like topical agents such as lidocaine and anti-inflammatories. Depression, interestingly enough, can also play a crucial role in perception of pain and is a major risk factor for the development of pain in many patients. Managing pain associated with HS, however, is very complicated. More often than not, a multidisciplinary approach is needed, and this usually involves a pain assessment, a pain scoring, and the involvement of many pain specialists. For people with unimaginable pain, so pain that it's like you literally just want to like lie in bed and just melt. These are the most severe cases, and usually short-acting opioid and analgesics, which are intense prescription drugs, are used to reduce pain. Although they are carefully administered, as these do have some side effects such as sedation, dizziness, nausea, vomiting, constipation, and physical dependence on the drug, so addiction. And this can also cause respiratory depressions. So it's important for whoever is prescribing this to first provide the correct dosage and to also consider if it is worth to risk some of these side effects, you know, as a trade-off of resolving the pain. In early stages of uncomplicated HS, topical antibiotics like clindamycin are the most effective and commonly used treatments. They help reduce inflammation and promote healing. In more advanced stages, oral antibiotics, especially those from the tetracycline family, are often prescribed. For treatment-resistant cases, combination therapies or hormonal therapies may be recommended. However, the use of antibiotics in HS treatments raises concern about antibiotic resistance. As I'm sure many people know, like when you get a cold and you take an antibiotic, people are like, oh no, you're gonna get a resistance to it. But yeah, studies suggest that prolonged antibiotic use may contribute to this issue. Consequently, there's a need to balance the benefits of antibiotic therapy with its potential risks, similar to opioids, but to a lesser degree. In clinical practice, there is some variability in antibiotic prescriptions between emergency department visits and HS treatment guidelines. Doxycycline, or whatever, is frequently used due to its convenience, affordability, and efficacy. It is often initiated in the emergency settings and continued by dermatologists or primary care physicians. For patients who can't tolerate doxycycline or don't respond adequately to it, alternative oral antibiotic regimens may be considered. However, it's crucial to avoid certain antibiotics in specific patient populations, and these could be people who are pregnant and those who are young, so like in your adolescence. Let's see. In addition to antibiotics, other medications like retinoids and biologics are being explored for the treatment of HS. However, these are typically managed outside of like emergencies or urgent care settings. So just, you know, when you're having like a quick visit to the doctor and not like having the sirens ring because you're in so much pain. So what if there's currently an open wound in the area? We can do some local therapy and wound care, and this involves a variety of approaches, including antiseptic washes, keratolytic agents, and topic antibiotics. The choice of the dressing also depends on factors such as the location of the lesion, skin condition, amount of drainage, cost considerations, and patient preference. For selected large wounds, so these are just massive areas covered in HS, negative pressure therapy followed by delayed reconstruction has shown promise in promoting healing. And this is essentially, you could think of it as manual lymphatic draining. This approach involves the use of negative pressure therapy for a short period, so this takes about 1 to 4 weeks, before proceeding with reconstruction of the area surgically. Another thing we can do is use intralesional corticosteroid injections such as Lord take me out, I'm just gonna spell it out. Triamcinolone. That one always gets me. can provide short-term control of acute and stubborn HS lesions. These injections often lead to rapid reduction in pain, edema, so that's just free fluid, so swelling in the area, erythema, so that's redness in the area, and suppuration and lesion size. However, the long-term effectiveness of this treatment remains quite uncertain, and careful monitoring for local side effects, particularly skin atrophy, so the loss basically of skin, is essential. While local treatments can offer relief in many cases and aid in wound healing, it's important to integrate them into a comprehensive management plan that addresses both local and systemic aspects of HS. So you don't always want to use it as a one-off treatment, you always want to use this in conjunction with something else to get the best effects out of it. Now, the administration of biologics or immunomodulation is gaining popularity for managing moderate to severe HS. This approach targets key inflammatory pathways involving tumor necrosis factors, so TNF, interleukin-1, interleukin-12, and interleukin-23. Basically, to summarize, all this causes inflammation in the area, and it's probably responsible for that chronic inflammation that you get with HS, and causes all that pain and all that scarring in the area. Now, something called adalimumab is recommended as the first-line biologic therapy for moderate to severe HS. The dosing regime for adalimumab starts with 160 milligrams at week 0, so the week you start, followed by 80 milligrams at week 2 and 40 milligrams weekly. And if patients do not show at least a 25 improvement in inflammatory nodules and abscesses within 12 weeks, so just if you don't see any improvements with the redness reducing and all that fluid draining decreasing, you basically discontinue the use of this drug. Patients who show partial or good response should continue the therapy with ongoing assessment. And basically, second and third line options include infliximab and anakinra. Other biologic therapies being explored for HS include tumor necrosis factor alpha blockers, ustekinumab, canakinumabs, apamilast, and gisalukbub. I cannot pronounce half of these, but I'll list them on the screen because God forbid me pronunciations do not work. But moving on, although these therapies show promise, evidence is still emerging, and clinical decisions should be based on close monitoring and careful risk-benefit assessments. Basically meaning it's case by case, so this might not work for everyone. It might work for what works for one person might not work for another, and then you also have to consider the risks. Like, is it worth the risk using this medication compared to, the overall arching goal that the person with HS wants to achieve? Now, most biologics are well tolerated and have a favorable safety profile in the short to medium term. However, long-term safety concerns remain, such as the risk of infections, malignancy, and demyelinating disorders. These risks are particularly notable in HS treatment, where biologic dosing tends to be higher than in other inflammatory skin conditions like psoriasis. Given these complexities, patient selection is crucial. And yep, this goes of the point I made before, not all patients will tolerate or respond well to these therapies, and complete responses are not the norm. Continuous monitoring of therapy effects and side effects is essential to ensure an optimal balance between benefits and risks. And if a biologic therapy proves ineffective or unsafe, other treatment modalities including surgery should be considered. And surgery is one of the, surgery provides one of the most drastic changes to the looks of the area and also the inflammatory aspect of it as well. Let's see. Laser therapies are primarily another treatment goal. A treatment modality that you can use, and its goal is on modifying disease activity in the groin and axillae. And this approach aims to destroy pilosebaceous units, and what this does is it helps prevent disease progression. So something called the Nd:YAG laser is a prominent option for many patients with early stages 2 to 3 diseases. And this laser is effective in reducing active nodules and has shown consistent results in controlled trials and case reports. In typical treatment settings, the Nd:YAG uses, okay, so this is going to get a bit technical, but it uses a spot size of 10 millimeters with a pulse duration adjusted according to someone's skin type. And when we talk about skin type, we're talking about someone's Fitzpatrick skin type. And this is essentially how much melanin someone has in their skin and just how they react in the sun. The darker you are, the higher Fitzpatrick, the lighter you are, the lower your Fitzpatrick. For example, a 10 millisecond pulse duration with a 35 to 50 joules per centimeter square for Fitzpatrick skin types 1 to 3. So these would probably be people of more of your white background. And a 20 millisecond pulse duration with 25 to 40 joules per centimeter square for skin types 5 to 7. And these are more of your African descent or maybe Asians. And generally 3 to 4 treatment sessions are conducted, with additional sessions potentially offering more lasting effects. CO2 laser therapy is also another option people might consider getting, and these are particularly useful for patients with fibrotic sinus tracts in early stages 2 to 3 of the stage progression. CO2 lasers are used for excision and vaporization of the affected skin. Retrospective series have shown positive outcomes consistently, although these studies are mostly uncontrolled. Another one is photodynamic therapy. These have been explored for HS treatment, and these are typically light-based therapies, and these basically reduce bacteria in the area and shrink the pilosebaceous units that are overreacting. And P. acnes is something that this is known to cause, obviously in the name acne, naturally produces perforins in sebaceous follicles, and these absorb light wavelengths between 400 to 700 nanometers, with 450 nanometer blue light being the most effective. Now, this light absorption excites something we call perforins in the skin, and this releases something we call singlet oxygens and reactive free radicals that kill P. acnes and any other bacteria in the area. So this makes it antimicrobial, and that can help prevent infection in the area. Red light LED, although less effective at activating that perforin, so it's less effective for the anti-inflammatory effect, can penetrate deeper into the skin compared to a blue light LED, and these target sebaceous glands and reduce inflammation by affecting cytokine release from macrophages. So cytokine releases more cytokine, an increase in cytokine basically increases inflammation. Blue light also can reduce inflammation in our keratinocytes or our skin cells, and our infrared lasers can cause phototoxic photodamage to our sebaceous glands. This can reduce their size and the amount produced, so that can help reduce that leakage that's occurring in the area. Other modalities such as our intense pulse light lasers and pulse dye lasers and our KTP, so these are potassium titanophosphate lasers, can also disrupt the sebaceous gland from functioning and kill any free roaming bacteria like P. acnes and anything else that can cause infection to the area through reactive free radicals. Now, in terms of treatment options, those are all the treatment options I know. Pardon me for pronunciation, because I just could not get a lot of these down even after sitting down with Google Translate ringing into my ear. But that basically wrapped up this episode. Thank you for tuning in. And yeah, follow me on TikTok, Instagram. I also have X or Twitter, whatever you call it now, and they're all named Skin Identities. And also stick around for next episode, where we will basically delve deeper into, you can think of it as a case study, where we'll just go more into depth about individuals' experience with HS. Hopefully we'll get someone to interview, but if not, we'll just really study a particular individual's or multiple individuals' experience with HS and see how it differs from person to person or how it's similar to each other. Thank you and see you. Bye bye.